So I just want to cruise through what we talked about yesterday real quick, just to recap, because I kind of struggled. Once reading this, it threw me off because I the way I had it lined up, it's not how I usually teach or talk about things. So the rhythm threw me off, and then my nerves got the better of me, anyways. But real quick, we have the heart, which is the the device that moves the blood through the body, right? The unoxygenated blood comes into the right atrial chamber, and then it moves through and goes to the lungs, collects oxygen, goes back out to the body. So the heart is made up of specialized cardiac cells. I need a face up here to look at. Hang on, sorry. Why can't I just have a little face at the top? All right, whatever. All right, so the heart is made up of specialized cells. They are pacemaker cells. What are they called? Myocardial. I can't remember now. Terrible. Myocardial cells, pacemaker cells, and they're unique because they will contract on their own, which gives the heart that automaticity. And what that means is you don't have to think about contracting those muscles to make the heart pump. It just happens automatically. And it happens because the chemical exchange that creates the little electric spark. That spark usually happens in the SA node, which is in the top right atrial. And we got a new little picture here for you. So up here is the SA node, where that spark happens. And when that charge contraction initiates, then all adjacent cells contract, and then all adjacent cells on that, and there's a wave of contraction that goes out. The right atrial chamber contracts first, down through the internodal pathways. You got 3. You don't need to know the names. You got 1 that goes over to the left. Don't really need to know the name. That impulse that goes over the left atrial chamber usually terminates over there. The impulses that come through the right atrial chamber will get to the AV node. The junctional area is just it encompasses a little bit of the lower atrial chamber and a little bit of the upper ventricular chamber right around here. You can see my mouse, right? Anybody?
Yes.
Okay. So you have the AV and junctional area. Then you have the septum. The septum is the wall between the ventricles, and you also have an atrial septum up here too. But I'm talking about the ventricle septum. Then you have the bundle of His through here, and the bundle of His is where all the bundle branch comes together, or separate really, and the left bundle branch and the right bundle branch, and down to the outside of the ventricles where you have the Purkinje fibers. I'm saying, Emily, how do you say that? Terrible pronunciation.
I think it's Purkinje, but I have no idea.
Okay, yeah. You know what I'm talking about. Little fibers, and then they contract the ventricles. And then you starts all over again. So the contraction, the depolarization of the atrial chamber is represented by the P wave. You have the PR segment, which is a little bit of delay from the ending of the P wave to the beginning of the QRS. That little delay allows the right ventricle to fill full of blood.
Sorry.
Nope.
I'm sending distracting notes in the chart. Just saying,
it's so small, I have to concentrate on what I'm looking at. So you have the PR segment, which allows the right ventricle to fill full of blood. Then you have the QRS complex that represents the contraction of the ventricles. The right usually goes first, then the left. Then you sometimes have a little isoelectric baseline after the QRS, before the T wave starts. The T wave represents the repolarization of the ventricles. That is the cells, the chemicals exchanging places back to get ready to charge again. The repolarization of the P wave, it happens right around the same time as the QRS does, and it's a tiny little blip that you'll never really see. So don't worry about that. You don't have to see it. You know it's happening because there's another P wave after the fact. If it didn't repolarize, there'd never be another P wave. So looking at the rhythm strip, it measures time. Left is the oldest, right is the newest. The page scrolls by at 25 millimeters per second. Excuse me. So one big box is 0.2 of a second. There's 5 little boxes inside of a big box, which is 0.04 of a second. And then 5 big boxes makes 1 second, which 5 times 5 is 25 millimeters. So when we talk amplitude, it's also voltage, and that's how high it goes off the baseline, up or down actually. So it could be a negative amplitude. So it'd be negative below the baseline or above the baseline. So P wave represents the depolarization of the atrial chamber. P interval, which we already talked about. QRS, we already talked about all this. And this is where you measure. It's all about the isoelectric baseline. And again, the isoelectric baseline is that flat line going through the rhythm the whole time. And that represents no activity in the heart. That's between beats. So once something starts to leave the baseline, the isoelectric baseline right there, that right there is where the P wave is starting to contract. And this is where the P wave is, when it returns to the baseline, that's when it's ending. This is where the P wave has ended and completed its contraction. Just like the QRS complex, it goes negative here. That's where the contraction starts. It comes back up to the J point. That's where the contraction ends. Normal PR interval is between 0.12 and 0.20. Big rule of thumb is 1 box is 0.20. So if you have a PR interval is the beginning of the P wave to the beginning of the QRS. That PR interval is greater than 1 box is usually long. And that's just kind of an eyeball measurement that you can do real quick. I'm cruising through this real quick. Any questions? Go for it.
Yes, you said 1 box is 0.20, 1 big box? Right.
One box here is 0.20 of a second.
Of the 5 small boxes together?
Yep. So small boxes is 0.04.
Okay.
Then 5 of those makes 20. And these are seconds. So it's 0.04 of a second. And then you have the big box is 0.2, so a fifth of a second. And then 5 big boxes is 1 second.
Okay, that makes sense. Because I like how you've been kind of, I think it helps train the eye when you talk about those quick measurements you can do or kind of recognize if it's taking up however many boxes. It kind of helps you put in perspective how much time it's taking. So thank you.
Yep, that's fine.
I see it. Okay.
And again, we're measuring time on the telestrip. It's from the left to the right, oldest to newest. So it's taken this amount of time for the P wave to contract, right? And then we have some abnormal measurements. We won't worry about those right yet. Normal measurements, PR intervals between 0.12 and 0.20. QRS needs to be less than 0.12. And then the QT is less than 0.44. Again, lead placement. Standard limb lead placement, you have white is right. The patient's right side is white. Patient's white is right. So you have snow over grass is how I remember it. And then on the patient's left, you have smoke over fire. So black over red. And that's the standard limb lead. And these can even be on the back. As long as they're somewhere in this upper quarter down here, that general area. Though, and all these leads, let me go to the diagram. So these leads, like lead 2, comes across here. So it comes across the white towards the lower left. So these leads are what you call bipolar leads, because it's using 2 points of not contact, but 2 points of reference to get the impulse from the heart, right? And they can be on the back, they can be anywhere surrounding. Saying that, the brown lead is pretty static, that landmark. It's on the right side of the patient's sternum, fourth intercostal space down from the collarbone. So that's the space between the ribs, just off to the right of the sternum. What that does is it sits on top of the right ventricle. And the brown lead is unipolar, just one lead. And how it works is it measures the strength of the impulse. If this is the heart and this is the brown lead on the chest, it measures the direction away from or towards the sticker itself, the lead, or away from the sticker itself. So that's why it needs to be right there, because if it's not on top of that landmark someplace else, it's not sitting on top of the heart. So you'll have you'll have a low amplitude or a bad picture of the V lead. So if you ever see like this just flat, and sometimes people are physically like that, they just have a poor picture. But a lot of times it's lead placement because the V lead's not sitting on top of the heart. And that's a common, it's just every day it's a conversation like, oh, he has a hairy chest, so we put it on his belly button. No, that's not how it works. Let's see.
That makes sense. Leanne will say that she often gets calls and it's like, it looks like it's just not in the right place. And then oftentimes it can be fixed because the leads aren't sitting right. Is that kind of, yeah.
So leads need to be changed daily. Is that still the process, Emily, for nursing, daily lead change?
Are you asking me about what a policy is?
Yes. Normally it should be daily lead change because, first of all, I mean, this is from the bedside. We wouldn't have anything to do with the bedside stuff, but it's the bedside people need to assess the skin integrity, right? And then after a day or so, the jelly that's with those leads will dry up and not look like, not give a good picture anymore. So they might look like, excuse me, interjection. They might look like, oh, look at that, Kristen. They might look like they're sticking to the skin well, the stickers, but because the jelly's dried up, they're not given a good image. So they need to be changed daily.
Yes, the technical policy is that they should be coming off because every patient in the hospital is supposed to get what's called a CHG bath. It's special wipes. When that happens, it's everywhere on their body, and that includes underneath the stickers. So yeah, they're supposed to be changed every single day. So that and hair grows back. So hairy chest guy that you had to trim his hair to get that V lead that Jeff was just talking about, that hair doesn't stop growing and it's gonna come back. So you got to take those leads off and kind of see, do we need to trim again?
And a lot of times, and these are little tips that you'll pick up once you're in the room. I will look at an EKG first of all before I even call the nurse. Like, this looks like a bad lead placement. The deflection's wrong. You'll start getting used to how lead 2 and V are supposed to look like, right? And like, it looks wrong, but maybe it's just the patient. So let's look at the EKG. And that is the 12 lead EKG where they put more stickers on their chest. And they tend to be very accurate because they're very particular about that. So I'll look at the 12 lead and I'll compare V1 and V. This should be in the same position. And I'll compare 2 and 2 should be in the same position. So if it looks great on the EKG and it looks like crap on our tele, it's a pretty good, safe to say, like, lead placement's wrong. And some people go like, whatever, who cares? I can see the rhythm. For the most part, it's like, if you can see the rhythm, sure. But like, if things happen and you're not getting a good picture, how can you actually say it's this or this? So that's my thought. There, cruising on. Quick calculations. I prefer the quick mental division where one box would be a heart rate of beats per minute of 300, two would be 150, 100, 75, 60. And if I really need an accurate measurement, I'll take it off the screen itself. Saying that, sometimes you can't trust the screen because the machine will sometimes read the QRS, the T wave, the P wave, and all this extra stuff, and then triple the heart rate. And you'll say, that is not 150 or whatever it may be. So you can do the 300 for one box, and you understand what I'm doing when I look at one box, one R to R's on either side of one big box, right? All these questions are directed to you, Elena.
Sorry, my computer was like flashing in and out weird. But yes, I think I'm with you. Say it again though for me because my computer was acting up.
So if I had a rhythm that had the R to R at this distance right here, I would quickly count 4 boxes. That'd be one box is 300, 150, 100, 75. And that just gives me a quick heart rate calculation.
Oh, yes. Yep.
If the R to R's are really fast together, really close together, and then it's like 1 or 2 boxes, like that would be beats per minute of 300. 2 boxes between it'd be 150. Sorry, you had a question there?
No, I like how when we were doing with the flutters yesterday, how you equated that ratio to those numbers. That helped me see it too. Like the 2 to 1 being exactly half. The one was half of that. Yeah.
And that's why I like this particular one, because first of all, it's quick, and then it equates to flutter, like you said. The other one, and that really, this measurement here is that the rhythm is regular, when the R to R is very regular. And nobody's perfectly 60 all the time. There's heart rate variation, 60, 63, 64, like nobody's perfect, but it's pretty close. When you have something totally irregular like AFib, you can do a 6-second counting strip. And what you have is on the screen, there'll be little black markers that give you 3 seconds. Right here, 3 seconds starts here to here. And this whole strip is 6 seconds. And if you count it out, there'd be 50 boxes on here. Because it's 5, 10, 15, 20, 25, 30. I can't do math. So 30. Yeah, that's right. 5 seconds, one. Yeah, there's 1, 2, 3 seconds. There's 6 seconds. All right. Anyway, sorry, that was a struggle there. 6-second strip, you just count the R to R's. 1, 2, 3, 4, 5, 6, 7. And you can roughly say that is a heart rate of 70.
Yes.
So saying that, you can see how this QRS lands right on this line right here. So let's do the quick calculation that I like to do. So one box would be 300, 2 would be 150, 100. 4 boxes would be 75, but this is inside that. So it's a little bit closer to that. So it's a little bit faster than the 75. So it's probably a little bit closer to 80 than 75. Do you see that?
Yes. And I think I was a little bit like worried it had to be exact with the boxes when it's not exactly from a bold line to a bold line, but it sounds like you can kind of see where it would lay roughly.
Yeah, like if the line is consistently, like I would say 300, 150, 100, 75, like you just kind of visualize shifting that over. So this would shift over there. So you could do it.
I see what you mean. Shifting it to that bold line.
Yep. So quick interpretation, like we talked about yesterday, whatever mental like checklist that you need in your head that you consistently use over and over again, just go down through that checklist every single time. This is my personal one where I first look at the heart rate. And what I mean by heart rate is that how tight or how wide is the R to R? Is it super fast, super slow, anything in the middle? If it sort of looks okay, I'm cool with that. Move on to that. Now is the R to R regular? If it's very regular, cool, love regularity. Is it irregular? Is it totally irregular where there's no rhyme or reason, no pattern? Probably AFib. We'll do another checklist. Or is there a pattern to is there a pattern to irregularity where there's, say, groupings like this, 3 here, 3 here, and I'm saying 3 hard R's. So totally irregular, probably AFib. But then my next thing is, how wide is the QRS? Is it basically within normal limits, just eyeball measuring it, or is it super wide? And then, is there a P wave present? And is that P wave consistently in the same place before that QRS? It doesn't have to be within normal limits, but is it consistently in the same place before every QRS? And then is the shape of that P wave consistently the same? Then, of course, you can measure the P interval. Is it long or short? So whatever you need to do to that mental checklist, and that kind of just goes through and helps you figure out what a rhythm is. All right, so your basic normal rhythms.
You are still zoomed in, I think, a little bit on your screen.
Is that too much?
I don't know. Depends what we're gonna look at. I don't know if that's, I think, a little bit less zoomed in. I can see more of what you're showing.
So I had it zoomed in, like, let's look at a strip. Whoops, I'm on the wrong one, sorry. So when you have strips up, can you see well, or is it here
Actually,
better?
that's not bad. I can.
This one here?
Yeah.
You're breaking up a little bit, sorry.
I see the whole strip, but I can see the portion of the strip well zoomed in.
Okay. So the normal everyday rhythms that we have are called sinus rhythms. And when you hear sinus, that tells you that the impulse is originating from the SA node up here. That is the normal, native, natural pacemaker of the heart. So that's where all the cells change their places and create that charge. And real quick, let's see. So there's inherent heart rates of all these cells and not the whole heart. When I say inherent heart rate is they normally tend to be between this and this. So the higher the heart rate's going to be. So up here in the atrial chamber, they are going to normally be between 60 and 100. A little bit lower in the junctional area, they're going to be between 40 and 60. And then down in the ventricular areas, between 20 and 40. So a normal sinus rhythm is usually between 60 and 100. So on the paper, what you're going to see is a heart rate between 60 and 100. You got 69 right there. You're going to have one consistent P wave within normal measurements. The P wave morphology is going to look all the same. It's going to be consistently before the QRS. Then you have a regular R to R. You get a T wave, and it just kind of regular. That's all you got for sinus rhythm. Then, of course, you have anything below that norm, below 60 is kind of sinus Brady. Same criteria, but the heart rate's a little bit slower. And that means the R to R is going to be a little bit wider apart. And then on the other extreme, you have sinus tach, where, again, the same criteria. The P wave is consistently before the QRS complex. P wave morphology stays the same, but the R to R is a little bit on the tighter side, where they're closer together. So that is all these sinus rhythms. And what's happening is the impulse is created in the SA node. Those cells contract. And again, all adjacent cells have a wave of contraction L. The SA node actually follows these pathways. They're called internodal pathways. And you don't need to know the names of these. This left one that goes over there is the Bachman. Then you got the winky back come down, a winky Bach that comes down the middle. You got like the lateral and the anterior. You don't need to know that. What you need to know is like if it's coming from the SA node, it's going to follow these pathways. Like the whole heart is a road, but these are like those commuter lanes. They get the nice easy route. So you have sinus brady, sinus rhythm all up in there. You can have sinus arrhythmia. Same criteria for all the other ones, just like we talked about. There's going to be a P wave consistently before the QRS complex. P wave morphology is going to stay the same. The P interval is not going to change around, but the heart rate is going to fluctuate. And I talked about this yesterday, where it's usually respiratory related, where you breathe in and your vagal tone changes and your heart rate kind of decreases. You breathe out, it increases. So you see this fluctuation from like 60s to 70s. You'll see it a lot at nighttime if you work overnights. So it's a little bit irregular. You see how the R is a little bit wider up here, and it's just a little ever so tighter down here. I think there's a better example here. You can see how right here it's a little bit tighter versus over here.
So that's just regular from breathing, but and it's called an arrhythmia?
Sinus arrhythmia, where sinus rhythm, the rhythm means regularity. Arrhythmia is irregular.
And you said breathing out, it increases?
Yes, I'm probably saying that wrong, but it's a 50-50 chance here.
It switches a little bit with breathing in versus breathing out.
Right. You can't make me look it up. Pretty sure it's breathing in. Emily, you got an answer?
No, I don't. Sorry, I'm losing this round of Jeopardy.
That's okay.
Oh.
You guys both win more than me.
I do know, like
Inspiration
even
increases, expiration decreases. So I was backwards. Sorry, Emily, go.
I was just gonna say with like nobody is gonna be perfectly on the money every single time unless you're like 100% paced, which is a whole nother conversation, but nobody's body is perfect and you're not going to always hit, like, let's say that the machine is reading your heart rate is 60. That doesn't mean that when you put your calipers on the R to R, it's going to be exactly directly on the money every time. And if there's a very slight difference between R to R, that doesn't necessarily mean that that person is in an arrhythmia. It's going to be obvious. Like this one that Jeff has on the screen, you can see just looking at it without measuring it that there's a difference versus somebody who their heart rate is 60 and you might find like a minuscule difference in the R to R. That's still going to be a sinus rhythm.
Not sinus arrhythmia.
Mm-hmm.
Yeah,
okay.
Because you can have a heart rate fluctuation, right? Nobody ever, like she says, nobody ever stays perfectly 70. But with the sinus arrhythmia, it's going to be quite obvious. It's going to be like a jump, like 60s to 70s, like I was saying. And like looking at that screen, like this page, it's obvious.
Well, and is sinus arrhythmia normal then?
Yeah.
Okay.
Yep. And I see what you're saying. Like arrhythmia sounds terrible. It sounds bad, but it is what we do. That's what it is.
Difference or an irregularity, but it doesn't mean it's bad.
Yeah. So, you have sinus rhythm, which is the regular version, and sinus arrhythmia is the irregular version. The irregular version usually has a pattern. And I want to harp on looking at that P wave. When you have an irregular rhythm, you want to make sure that P wave is consistently the same. Because if you have a different P wave, it's something else, which we haven't talked about yet. Oh, we did yesterday, but we'll talk about it again. I'm going to skip pauses, skip that. All right, so backing up real quick. So the inherent heart rates, you have the atrial chambers between 60 and 100, the AV junctional areas between 40 and 60, and the ventricles between 20 and 40. If for some reason the SA node was to fail, like it just stopped working, so there was a pause, all these cells below still have that automaticity, that action potential to contract on their own. Normally, when the SA node fires first, it forces everybody below to contract, and it kind of puts them in suppression. But if the SA node was to fail to fire, those cells below start to waken up, and they want to contract on their own too, because they have that automaticity. So if the SA node was to fail, the cells below the atrial chamber have the potential to pick up the slack and contract. What you're going to see is you're going to have a P wave, but the P wave is going to be different than what you saw before with the SA node, a different morphology. So if it's high up here, it will still be positive because it still goes down that normal pathway and goes through the AV node and contracts the ventricles like a normal would. If it's on the lower side and physically lower in the atrial chamber down by the junctional, it could be negative where it has to still go back up to tell the atrial chamber what to do. But ultimately what I'm saying is the P wave would change, and that kind of goes back to that sinus arrhythmia. So if you have an irregular rhythm, you got to make sure that P wave is the same P wave, because if it's a different P wave, it could be one from here, one from in the atrial chamber. So as that SA node fails, that heart rate is going to drop a little bit. So you're going to see another P wave come in at a slower rate. And then for some reason, the SA node in the atrial chamber fails, it's going to get to that heart rate of 40 to 60, and the AV junctional area will take over. And if all these three fail, the heart rate's going to be even slower, and the RR is going to be really wide in that 20 to 40 area, and then the ventricle will contract and do something on its own. Because all these impulses above come down this normal narrow pathway, this natural progression down through the narrow part of the QRS, they have the narrow part of the heart, they have a narrow QRS complex. If the ventricle contracts on its own, originating somewhere down here, it's coming from the stronger muscly part of the heart, and you're gonna have a bigger, wider QRS complex because it's coming down from here. It's a big, strong impulse. Questions there?
No, I'm good with that.
All right, I threw a lot there.
No, and it kind of makes sense that it would get wider as it goes down further. I don't know why. That feels like it makes sense that those RRs would be wider. But I think I'm okay with that.
Okay. All right. So below the sinus node, below the sinus rhythms, you have the atrial rhythms. So the impulse, the P wave is no longer coming from the SA node. It's now come from the atrial chamber itself. So what you have will be a different P wave. So this is what you call an atrial ectopic rhythm, where this P wave is probably coming from the SA node. And when you look at P waves, you want to focus on lead 2. When you look at the QRS complex, you want to look at the V lead. The V lead on all these strips will usually be on the top, 2 will be on the bottom. Where I'm working now, it's reversed. So you just have to get used to that. But again, look at lead 2 and look at the morphology of the P wave. You can see right here it changes. So where this one is a little bit pointy, still positive. Or sorry, this one's over here still positive, but it's a little bit on the shorter side, a little bit more rounded. These two are totally different. You see that? Do I need to blow it up for you?
Oh, no, I see that.
Okay. And also look at the heart rate. See how this over here is a little on the faster side, and then it slows down a little bit. The R to R widens just a hint.
Mm-hmm.
That's the heart rate change coming from a different area. All those cells up there in the atrial chamber and the SA node, they all have their own inherent little heart rate. You know, one over there might be 66, one over there might be 81. So you have that heart rate fluctuation. So it won't be regular anymore. So like comparing that to the sinus arrhythmia earlier, where it's irregular, but it'll all have the same P wave. This irregularity is because each P wave has its own little inherent heart rate.
Sorry.
No. Kristen, how you doing? Can you hear us all
Good.
right?
Oh yeah, good. I'm
You
doing
learn
good.
anything?
Of course, yes, always. Good stuff.
Oh, we haven't got to the good stuff yet. You want to take over for me, Kristen?
No, you go ahead. You're doing great.
Give Lane here a second. Aw,
Okay.
puppy.
He's a barker though. This one is lazy.
Oh, that's my kind of dog right there.
Yeah, same. But I think I'm okay with that. The P waves are,
Different.
they look a little bit different from each other, but they're both positive.
And it doesn't always have to be positive. It's going to be different though,
Okay.
right? Where this next example, clearly different. Over here, you have this positive, a little jagged on the top, a little bumpy there. This one's negative. This one I would actually call some premature ectopic. See how it's a little bit tighter, and then you have this gap of time where it's compensatory pause. We're just going to ignore this guy for now. But we're comparing these three here to these three here. So these we're going to call the SA note because they're positive and they're going down through the heart, right? Where this P wave here is biphasic, below and above the baseline. So this P wave, it tells me, is starting lower in the atrial chamber. So it has to go back up first to tell the atrial chamber what to do. And at the same time, that impulse is going down also. So that's kind of why I like that triangle example above, just to get used to what lead 2 is going to look like and the deflection. So normally a P wave in lead 2, and this one happens to be 3, but to lead 2 and 3, a P wave will be positive or should be positive if this is coming up from the SA node. This one is only because I know it's coming from the lower left atrial chamber. You don't need to know those details, but you just need to see the different P wave. So this would be an atrial rhythm where you have 2 different P waves. One's coming from the SA node, one's coming from the atrial chamber. Kristen here with us. She's an old pro. She's been doing longer than I have. She's even older than I am too.
I am not older than you. All lies. Hi, Emily.
Hi,
How you doing?
pretty good.
Awesome.
All right, we're going to skip this guy here. So, wandering atrial pacemaker. So, in atrial ectopic rhythm, you have 2 different P waves. A wandering atrial pacemaker, you have 3 or more. That is the difference. So, with wandering atrial pacemaker, there's usually a clear cycle of P waves. And what I mean by that is there's going to be some P waves come from the SA node, and then there's going to be some P waves come from the atrial chamber, and then there's going to be some P waves coming from the junctional chamber. So what you're going to see is a progression of positive, something in the middle, then negative. So you can see right here is they're positive, and then they go flat, like something different right down there, and then they're negative over here. So that is a classic wandering atrial pacemaker. You'll have this cycle of P waves where it's positive, flat, negative, positive, flat, negative. And sometimes they'll actually stay negative. They'll stay in that junctional area. And we haven't talked about junctional stuff yet, but we will in a second. Excuse me.
Is it pattern? Is it patterned irregularities with the P waves with the atrial ectopic rhythm, or could it not be a pattern?
Not necessarily. You'll see a pattern to the irregularity more because of the heart rate will change, where it'll be a little faster over here with one P wave, and it'll be a little slower over here with another P wave. So there'll be that pattern, that irregularity with a pattern in a sense. But Only that, I think.
That makes
That
sense.
answers. So then you have wandering atrial pacemaker. Instead of just 2 P waves with an atrial ectopic, you now have 3 or more. There is another one that we bundle in with wandering atrial pacemakers, which is called a multifocal atrial rhythm. And it does not have that pattern like the wandering atrial pacemaker does. Instead, the impulses come sporadically from all over the place in the atrial chamber. Some of them can be from the SA node, some of them can be from the junctional area, but they're usually from all around in the atrial chamber. So you just kind of have this. Let's see if I can. It's really not the greatest example, but you can see how they sort of change where they're positive, they're still positive to the flat, they're a little bit flat, they're pointy over here. So they're all kind of like different P waves, but they're still all positive. But we just still, if it's 3 or more different P waves, we're just going to call it a wandering atrial pacemaker. These little nuances are just because I'm a nerd.
And that sounds good. I misspoke though. The pattern, I was asking about the wandering atrial pacemaker. Well, it might not be a pattern, but there will be 3 or more different types of P waves.
Yes.
Okay.
Yes. Again, 3 or more different P waves. You got pointy ones here, biphasic, then negative, then tiny pointing. Again, 3 or more different P waves. Yeah, don't say WAP.
That wasn't what I was saying. You didn't read the whole thing. First of all, do say WAP. I'm saying we use the umbrella term of wandering atrial pacemaker, and that's already confusing to most nurses. Like most of the time, if you call them up and you're like, hey, just so you know, your patient is in a wandering atrial pacemaker, 90% of them are going to be like,
They don't have a
WTF is
pacer.
that? Yeah, which is a literal answer that Jeff got when he notified a nurse that his patient was in a wandering atrial pacemaker. The nurse said he doesn't have a pacemaker. But anyway, just that part alone already confuses a lot of nurses. So then on top of that, adding in the multifocal atrial rhythm, nobody's going to know
Too
what you're
much.
talking about.
Yeah.
That's good to know though. So even if it is multifocal, it's okay to communicate with the nurse that it's just a wandering atrial pacemaker. And then
We bundle them together for sure.
okay, and then of course having some knowledge about what that is so you can talk to the nurse about it and help them. I'm sure it helps if there's any confusion, but that's helpful too. But those can kind of just be together.
So these rhythms that we've talked about, they're pacemaker cells. So the SA node is a pacemaker cell. This atrial ectopic rhythm is a competing pacemaker cell, where it's not waiting for the SA node to fire or the heart rate slowing, it's taking over. So they're competing pacemaker cells. And I'm emphasizing this difference because there's a difference between pacemaker cells and excited cells. And now we're going to talk about PACs. So PACs, premature atrial contractions, are excited cells in the atrial chamber that want to come first. So they get excited. They don't wait for the SA node to tell them what to do. They just do it on their own. So what you're going to have is hopefully a normal rhythm, and all of a sudden you're going to have a early beat. That R to R is all of a sudden going to get really early, really tight. But you'll have a different P wave because it's no longer coming from the SA node. And it's sometimes it's not, you're not always going to see that P wave. It's not going to be obvious like, hey, look, there's that different P wave, but you're going to see this early R to R, right? You see that? And then you see that T wave right there. You see how that T wave is a little bit more pronounced than this one over here. See that extra little bump on that, how it stands up a little bit more?
Yeah.
Right? So that is the P wave of the PAC sitting on top of the T wave. It's all kind of merging together. And we know this is a PAC because the beat comes early, but then it follows the normal natural pathway of contraction down through the septum, through the bundle of His, and contracts ventricles through the Pachinki fibers. And we know that because it has a narrow QRS complex.
I see that.
So PACs, premature atrial contractions. And after any sort of ectopy, ectopy is like anything outside the normal. And PAC is an ectopy beat. So after ectopy, you have what's called a compensatory pause. Compensatory pause. And that's just a little extra gap of time between R to R's where the heart rate is like, all right, something threw us off a little bit, and now let's get back in normal rhythm.
Might be a silly question. Will you ever
Never.
have a compensatory pause if it's not after a PAC? Or is that if you see that long pause, can you assume there's a PAC, or would you still want to look for that abnormal TP together and that
So
narrow QRS?
you can have pauses that are not compensatory. So there are sinus pauses where the SA node has failed to work, which I skipped above.
I have notes from yesterday. We did talk about that. It's
I know,
it looks different.
So a sinus, I mean, we can go back up if you want. So actually, let's just go here. So sinus pause. Where are we? All right. So this is a very exaggerated example, but what's happening is the SA node is failing to fire, right? The sinus node is pausing. And for some reason in this instance, the cells below did not pick up the slack. The atrial chamber didn't kick in, the junctional didn't kick in, and the ventricle didn't kick in until 9.5 seconds later. Then they finally decided to come back. This is an extreme pause where we really just call it a sinus arrest. Asystole, and that's kind of the nuances. Asystole is everything just stops, never comes back. Sinus arrest, it'll eventually come back. Sinus pause is just a smaller amount of time. Because we talked about yesterday, like the machine is constantly measuring that R to R. If it has unusual gap, it'll ring misbeat up until 2 seconds. 2 seconds of time or more, up until 4 seconds, it'll be a pause. 4 seconds or greater, it'll ring asystole. But sinus arrest, the SA node just stops, doesn't come back. Asystole, everything stops. Actually, it's everybody uses it interchangeably. So sinus pause. Go back to your question. You have no PAC, right? You have no extra P wave. It's just a flat line. So there will be times where you'll have pauses that are not because of ectopy.
That makes sense. And you kind of use your other aspects that help you cue in if it's a compensatory pause after a PAC or not.
Right, because you would have an early beat. Yeah.
And those QRS complexes look different there on the sinus pause versus the PAC. So
they do down here because something else has taken over. They're still narrow, so that's a good thing because that means they're still coming from above the ventricles. Otherwise, and that's where you want to differentiate between wide and narrow. If it's wide, it's coming below in the ventricles. These are still coming someplace above the ventricles, which is good for the patient. Let's see.
You said wide is coming from below, which does that mean the SA node, it didn't fire and it's coming from those backups?
So again, if the heart rate drops, or anything originating from the ventricles, the lower chambers, the right and left ventricle, anything originating solely there is going to be a wide QRS when it's a bigger QRS complex.
Okay.
Where if it's originating above in the SA node or the atrial chamber, it follows that normal natural pathway down through the septum, the bundle branches, where instead if it's coming from the ventricles, it just goes up. So you're gonna have a wide QRS.
Okay.
Sorry, I've got the computer timed out. All right, so other atrial rhythms. Let's get these guys for now. We talked about flutter. How do you feel about flutter? Want to go over flutter again?
I feel pretty good about flutter.
Okay.
And then even, I've got to look at my notes, but you said flutter can sometimes look like, I can't remember which one you said. I have it written in my notes, but I could see the difference between the consistent.
Coarse AFib can sometimes look like flutter.
Yeah, but I feel good about.
So flutter, the atrial activity of flutter. Oh my God. Awareness mode sucks. So the atrial activity of flutter is going to be very regular, right? And the rate of that atrial activity is going to be right around 300, one big box. And then there's going to be, yes, we'll get there. There'll be intervals like we talked about earlier, where it's a 4-to-1, the 4 flutter waves, 4 atrial activities, 1, 2, 3, 4 to 1 QRS complex. If it was a 1-to-1, if it was a 1-to-1 flutter, the ventricle is responding to every single flutter wave, which would make the ventricle 300 beats per minute, which is not good for the patient. If it's a 2-to-1, it's 150 heart rate for the ventricles. 3-to-1's 100, 4-to-1's 75. Because the flutter waves are very regular, the responding QRSs are usually very regular. But again, they are initiating above the ventricles, so it's following that normal pathway down and contracting the ventricles, so you have a normal narrow QRS complex. There are times, let's just go to this picture down here. There are times you'll have a variable conduction, where up here it's a 4-to-1, and sometimes it'll fluctuate. But like this one is irregular, but there's a pattern to the irregularity. There's grouping, like I was saying, like there's 2 here, 2 here, 2 here. All right, why is it 2 here? They look like flutter waves, so that's like a 4-to-1. Then there's a 2-to-1, 4-to-1, 2-to-1. Same thing down here. And what Emily was saying, sometimes it can look like sinus tach, where when you have a 2-to-1 flutter, this is like just a classic looking 2-to-1 flutter, you could quickly look at that and say, oh, there's sinus tach. But that heart rate is rarely ever going to fluctuate from 150. It's just going to be that heart rate trend is going to be just consistently 150, and it's never going to move until they break. And then this little notching, this sawtooth pattern, this notching between the RRs, it's just kind of a classic looking 2-to-1 flutter.
When you say the notching, like the classic look, are you talking about how like it doesn't go back to the isoelectric baseline? Like you can't see it's like kind of going down, like just barely touching it and then going right back up. Is that what you mean?
Absolutely. Right, exactly. There is no isoelectric baseline, just like this guy up here. I say that. Like, let's look up here instead. So you can kind of see how the flutter activity goes right down and just transitions immediately into another flutter wave. So with flutter, there'll never be any isoelectric baseline between the atrial activities. If you need me to pause, just say so.
I'm good with that.
I'll drop in here. So the other atrial rhythm is AFib. usually roughly two forms of AFib. You have fine AFib and coarse AFib. And like we were talking about just a second ago, coarse AFib is the atrial activity of AFib is just a little bit more pronounced. So with AFib, excuse me, actually, let me back up. Let's talk about flutter real quick. So flutter is the atrial activity of flutter is very regular because there's a very regular pattern to it. So it usually originates in the tricuspid valve, goes up the inner wall of the septum between the atrial chamber, across the roof of the atrial chamber, and then down the lateral side of the atrial chamber. And it consistently does a circle right in here. And every time it passes the AV node, it tries to get down through the AV node and tell the ventricle what to do. But the AV node is a gatekeeper and doesn't let the majority of the impulses go through. And that is why you'll have that consistent pattern flutter right there, because it's a very regular pattern of contraction in the atrial chamber. Where a fib, the atrial chamber is literally in a muscle spasm. It's just sitting there and quivering, and sometimes it can quiver up to 600, 800 beats per minute. So all this little roughness through the baseline here is the atrial chamber just quivering and contracting. There's no rhyme or reason to the muscle spasm. It's just kind of all over the place. With coarse AFib, like if you were to look at these three right here, like you're like, oh, maybe that's flutter, but you kind of follow them all through. That coarse AFib will kind of become stronger and weaker. It'll wax and wane, where the how pronounced it is on the isoelectric baseline will come and go. So that's the one that we were talking about that could look like flutter sometimes. But you just have to look at the big picture. It's like, okay, first of all, is that atrial activity consistently through the paper and all the beats? No. All right. And the other big clue is with AFib, it will be irregular. There's no rhyme or reason to the irregularity here, where you can have an irregular flutter, but there's going to be a rhyme or reason to it. There's going to be a pattern. Of course, AFib, there'll be no pattern. Just irregular.
That makes sense. Same with the compensatory pause. It's not just the pause or the one section alone that'll help you determine. You have to look at the big picture for both and use your tools to see what it is.
Yep. So the flip side of that is fine AFib. And you can probably see where this is going, where how pronounced the muscle spasm on the isoelectric baseline is not as pronounced. There's a little roughness in there, but you can kind of see it through there, but it's not as pronounced as coarse AFib. But your big giveaway is like there's no consistent P wave. Every once in a while with AFib, you're like, oh, is that a P wave? Maybe it looks like one, but is that P wave consistently there before every QRS? There's no consistent P wave. So with AFib, there's no P wave, and then it's irregular. There's no rhyme or reason to this irregularity here. So this again, AFib, but the fibrillation is on the fine side. Yes. You talk about the flutter waves, Kristen, or the R&R? The flutter waves will be very consistent. The flutter waves will be march out, like you said. If it's and like I was saying, the R&Rs tend to be regular, but they can be irregular, but they're usually with a pattern. All right, so those are the main features of the atrial chamber. So let's talk about the junctional area. So again, the junctional area encompasses a little bit of the lower atrial chamber and a little bit of upper ventricle chamber. Excuse me. And the junctional is two forms of junctional. You can have excited. Let's talk about ectopic pacemakers here. Not ectopic, but all right, so junctional P waves. If for some reason, again, if the SA node was a fail and doesn't create P wave, the atrial chamber has the opportunity to pick up the slack. If the SA node and the atrial chamber were to fail, the junctional will pick up the slack. But the heart rate's dropping. It's dropping to 40 to 60. And what's happening is these cells down here, they still have that automaticity action potential, and somebody above hasn't told them what to do, so they just contract on their own. But because they're just below the AV node, that impulse, that wave of contraction is going to go up and down at the same time. So because it's going up to the atrial chamber, away from the positive, and remember your triangle, the positive's down here, it's going away from the positive, you're going to have a negative P wave. So if we look over here, so let's go to the bottom part of the strip right here. You see how it's nice and positive down there? This is the sinus bit. And up at the top, this particular P wave is retrograde. So this negative low dip after the QRS complex, that is your P wave. I shouldn't have started with that example. All right, here's a better example. So, sorry. So the inherent heart rate of the junctional area is between 40 and 60. If it's a little bit faster than 60, it's called accelerated junctional. And you can kind of see where that negative P wave is right there, just before the QRS complex. So this heart rate is, let's see if we can find one that lands right on the box. Of course not. Right, there's 300, 150, 175. So it's almost exactly 75 beats per minute. So it's above the inherent heart rate of the junctional of 40 to 60. So that's an accelerated junctional. If that heart rate continues to increase and go above 100, then at that point it's a junctional tach. Just like sinus tach is above 100, junctional tach would be above 100 too. So you have three different possibilities. I'm gonna have to actually draw this one out. Oh, wow. So your SA node's up here, and the junctional area, like I said, encompasses the little bit of the lower atrial chamber and the upper ventricle chamber. So if the junctional cell is originating up here in the upper part of the junctional area, the P wave is going to be just before the QRS complex. That's going to be very close. And think of it as travel. So there's two criteria. Sorry, let me back up. There's two criteria for a junctional P wave. The PR level has to be less than 0.12, and it has to be negative. So a normal PR level is between 12 and 20, right? 0.12 and 0.20. So it's going to be very close to the QRS complex, and it's going to be negative in beat 2. So that is if it's happening high in the junctional area. If it's happening someplace in this middle septum, it's going to be buried inside the QRS complex. If the P wave of the junctional P wave is happening someplace in the lower junctional area, it's going to be retrograde after the QRS complex, and then into a T wave. What are your thoughts on that?
I guess it's strange because I've always just thought that P wave is gonna be before.
Right. So if we're talking sinus rhythms and atrial rhythms, absolutely. But we're now getting lower in the heart. You know, up here where the P wave is normally activated, it has that time of contraction coming down. You know, think of it as travel time. If the P wave is originating down here, it doesn't take as long to get down here. And so that's why it's really close to the QRS complex. If it's below here, it's, you know, the QRS is happening almost at the same time. You know, it's, so you can have it's what's called a retro. Go ahead. Sorry.
Oh, no, I was saying that makes sense. It's called retrograde, and that's if the impulse is coming from the ventricles, the area of the ventricles.
It's lower. It's not purely coming from the ventricles yet, but it's lower in the junctional areas, the upper part of the ventricle, yes.
But lower junctional area.
Right, but it's still going to be a narrow QRS complex because it still goes down that normal flow of the septum down to the bundle of His through the Bajingi fibers like it normally would. Pictures. So Kristen just asked, Kristen asked that again? Sorry, the message is gone.
Oh, what if it's less than 0.12, but I mean, yeah,
Positive.
less than 0.12, but positive.
Oh, so what she's asking, what if it doesn't fit the criteria of junctional? Like say for instance, is the PR of less than 0.12 or less than 0.12 but still positive, or if it's negative and the PR is greater than 0.12. So what you're going to have here is an atrial ectopic, where the atrial cells someplace around the junctional area, they're still low, but they're high enough to still create a positive P wave because they're still originating down there. To be junctional, you have to be, the PR level has to be less than 0.12 and negative. If it's not less than 12, it's coming from up here, or if it's positive and less than 12, it's either way. If it doesn't fit those two criteria, it's going to be an atrial ectopic, which is someplace up here, close to the junctional, lower down there, but still creating that positive P wave because it still flows down this way.
Okay. Got it.
You okay with that, Kristen?
Yep, good.
And it's a conversation all the time. Like, oh, it's a negative P wave, right? Well, no, it's like 0.16. You can't call that junctional, right? It has to be less than 12. So you can consider either maybe lead placement, because if these leads are swapped, oh my God, it's awful. If these leads are swapped, it's gonna be different, right? It's going to have a negative P wave because it's still traveling in this direction, but the positive is now up here.
Yeah.
All right, can I clear this? So, competing pacemaker cells versus excited cells. So just like PACs, premature atrial contractions, you can have excited cells in the junctional area, and they're called PJCs. Same thing. They're going to be the same criteria. You're going to have a negative P wave. You can see that little guy right before that. But then you're going to have an early QRS, and you have compensatory pause after the fact. A lot of times you'll see PJCs and just call them PACs, because when you have that early beat and it squishes together that previous last T wave, everything gets squished together. It's kind of buried together, and as long as it's narrow QRS, I wouldn't fault you on just calling them PACs. But this one just happens to be an obvious negative P wave right there, where it's positive there, negative there. So PJC, premature junctional contractions. So that's an excited cell in the junctional area. Again, quite obvious negative P wave right there. Compensatory pause, still a narrow QRS complex. All right, SVTs. Supraventricular tachycardia. So that's what SVT stands for. Supra means above the ventricle. Supraventricular tachycardia. So what it's saying is there's a sudden onset of narrow QRS tachycardia. All SVT is a bunch of PACs in a row. Instead of one PAC, you have, where's it? Yeah, this is my next thing. So I need to reorganize this. It's not the way I talk. I'm sorry.
You're fine. I'm taking notes though. You said tachycardia is just a bunch of PACs in a row?
SVT, supraventricular tachycardia.
Is a
All
bunch
PACs in a row.
Okay.
Yes. Okay, let's use this one right here. So SVT is an umbrella term. And there's a lot of better labels under an SVT, but generically speaking, broadly speaking, SVT means you have a sudden onset of tachycardia, anything over 100, and the QRS is still narrow. So, if somebody converts to AFib or flutter, technically that is an SVT, but we have a better label for that. Because we can see with AFib the irregularity and there's no longer a P wave, so we can call it AFib. But generically, broadly speaking, it is a form of SVT. If you look here where somebody was really nice to draw a line, on the left side, you have sinus rhythm, and you can see the nice P wave consistently before the QRS complex, and this beat right here, PACs. That heart rate increases. You can see the P wave sitting on top of the T wave, because with PACs, it's originating from the atrial chamber. You'll still have a P wave, but it's going to be a different P wave. It's no longer coming from the SA node, it's coming from the atrial chamber. So it's really hard to see the different P wave morphology, but that sudden onset right there, that tells you this is an SVT. Because where sinus tach can get fast, it's going to increase like 90, 95. 110, 150. There's going to be that gradual change, where SVT is literally this right here to this right here.
really emphasizing that sudden onset of
Yes.
heightened and staying heightened.
Yep. Because like before with PACs, you have that one early beat, right? And now we just have a bunch of those early beats in a row. And you can have short runs of it. You can have like 2, 3, 4 PACs in a row. This one just happens to go on.
So SVT, I guess it can be just a few early beats
Yes.
suddenly and then return to normal.
So we have different labels, like a salvo or non-sustained. It's like 3 or 4 beats of PACs. You can use that label for PBCs too, which we haven't talked about yet. But this short little run of SVT, usually you don't call it SVT until, I don't know, like 4 seconds or something, 3 seconds. And when you say 3 seconds, see these black lines right here? This distance right here is 3 seconds.
Nice. I do see those.
So all SVT is a bunch of PACs in a row. So there's a couple different labels under SVT, like I was saying. You have, AFib and flutter. You have PAT, proximal atrial tachycardia, is when you can clearly see the different P wave. And you can see the P wave on top of this T wave right here. So that little notching. You don't have it over here, but you have it right here. So you have one sinus beat here, and these are all PACs. This particular example is a little different looking because it has a bundle branch associated with it. And then there's really very few sinus beats on this. You get a sinus beat here, you get some sinus beats there. It's a sinus beat, then some PACs. This little salvo, a non-sustained SVT. Yeah, 1, 2, 3 PACs, PAC. This would be a short run of SVT. But again, SVT, just a sudden onset, a narrow QRS tachycardia. If you have the QRS change, get a little bit wider from the sinus bit, then you're talking about something else. But all these QRSs are the same. Even though it looks ugly, all the QRSs are the same here. So another form of SVT is MAT, multifocal atrial tachycardia. What that means, multifocal. So there's different excited cells in the atrial chamber. With each individual cell, you're going to have a different P wave morphology. Each individual P wave has its own little inherent heart rate. So it's going to be irregular. So you can see how this is not the most regular thing, but you have these little bursts through here. Then look at the P waves. You can see how this P wave here is different than this P wave here. That one's buried on top of the T wave. That one's different. So MAT can be confused with AFib, where that irregularity of MAT, multifocal atrial tachycardia, is irregular because of the different P wave rates, where AFib is irregular because of this muscle spasm of the atrial chamber.
So they do look pretty similar, but it's just caused by different things.
Between AFib and MAT?
Yes.
Yes. So with MAT, there's, even though it's an unusual rhythm, it's SVT, it's still contracting to a organized atrial activity, where even though it's an excited P wave, excited cell creating those P waves in different places, it's not AFib where the muscle is literally in a spasm and just randomly contracting.
Got you. Thank you.
Junctional skips there. Let's go to ventricle stuff. Talking to Emily last night, and like I pitched this as a beginner stuff, but like a lot of this shit is like needs to be part 2. Like I'm trying to just go over the true basic stuff. MAT is just way over 100. Oh, all SVT would be over 100 though. Okay, so there is a difference between wandering atrial pacemaker and MAT. This is going to be for Kristen. So if you think about wandering atrial pacemaker, those are ectopic competing pacemaker cells, where MAT are excited premature cells. So saying a wandering atrial pacemaker, or sorry, saying a MAT is just a fast wandering atrial pacemaker is not really accurate. Even though we do it, and I've said it before, it's not accurate because it's 2 different cells activity. Wandering atrial pacemakers at competing pacemaker cells, where MAT is the excited cells that are coming from all over the place. It's a little nuanced. I know we just say an MAT is a fast wandering atrial pacemaker, but there is a difference. See, you learned something today, Krista. Okay, so we're getting down into the ventricle stuff, and if I can find it, sorry, I'm struggling here. All right, so talking about the difference between ectopic pacemaker cells, competing pacemaker cells, like with sinus and an atriotopic rhythm, right? The sinus is the natural pacemaker of the heart, where an atriotopic is a competing pacemaker cell. So then you have 2 different P waves. You can have competing P wave or competing ectopic pacemaker cells in the ventricle too. And those are going to be called an idioventricular, if I can find it. Yeah, right here. So this would be what you call an idioventricular rhythm. You see here you have a nice sinus rhythm. You got a P wave, and then a slight delay. The heart rate drops a little bit. the ventricle is taking over. You see how much wider this QRS complex is? This R to R is very regular. And there is a cell in the ventricle that just wants to take over. And that's what's happening right here. So this is a competing pacemaker cell in the ventricle. It's which is called idioventricular rhythm. Usually idioventricular is between 40 and 60. Then you have accelerated, that's up to 100, like 60 to 100. And then if you saw a wide fast rhythm go over 100, say err on the side of caution, just call it VTAC, which we haven't talked about VTAC yet, but I will in a second. I should have started with that, sorry. So you can have competing pacemaker cells. You have the natural one is the SA node. You can have a competing pacemaker cell in the atrial chamber. You can have a competing pacemaker cell in junctional. And you can have it in the ventricle too. But what you're going to see with all these is there's a slight delay where if it's early, like down here, see how these are premature and they're all squished together? Those are excited ventricle cells down there. So, and that's what you call PVCs, premature ventricular, PVCs, premature ventricular contractions. So I'm just going to use this example to cover both things. So just like PACs and PJCs, PACs, premature atrial contraction, PJCs, premature junctional contraction. You have PVCs, premature ventricular contraction. And again, there's a difference between pacemaker cells and excited cells. These excited cells, they want to come, they're excited and they just want to come first. Then you have a compensatory pause after them. Where idio is a competing pacemaker cell, there's a little, it's like the opposite of a compensatory pause, but there's a little gap of time before that extra rhythm kicks in. I just threw a lot at it. What do you think of that?
I think I'm okay with that. I was trying with this course that I'm doing to look at different rhythms and label them what they were. And I was having a hard time understanding what makes it idioventricular. So I think now after talking about the PACs or the PVCs and the difference between the excited cells, I think I'm getting a better understanding of it. So I think this makes sense.
And what you want to see is that big, wider QRS complex, right? You have this normal kind of narrowish QRS with the sinus over here, and then it changes to this big, wide QRS complex over here. There are other things that make a QRS complex wide, but for right now, we're just going to call them PVCs. So we have PVCs, or sorry, we're going to call that idio. And really, anything coming from the ventricles can be a big, wide QRS complex, both PVCs and idioventricular. But the nuances between PVCs and idio is the difference between an excited cell and an ectopic competing pacemaker cell. So just like SVT being all a bunch of PACs in a row, a bunch of PVCs in a row is VTAC, ventricular tachycardia. So instead of one PVC, you're going to have a bunch of them. Let's see if I can find something. Here's another example of a idio. You can kind of see how the sinus is right there, and then you have this gap of time. This is one continuous strip, right? It starts there, continues here. So this is this heart rate slowing down, then the ventricle kicking in. Idio. So there are two forms of VTAC. One is monomorphic, which means all the PVCs are coming from the same place and they look all the same. This is a particular example. You don't actually get to see the sinus, but this is VTAC right here. This is your T wave. This is your QRS complex right here. And just immediately merges and transitions into another contraction. So this heart rate, if you do the quick little calculation, let's see. So one box would be 300, two would be 150, but we're right in the middle of the second box. So it's probably close to 180, 200 right there, that ventricular contraction. So this is monomorphic VT, ventricular tachycardia. And all that is a bunch of PVCs in a row. Not good for the patient, by the way.
And then just to keep me straight, supraventricular tachycardia is also a bunch of, oh, that's PACs in a row. We're talking about PVCs now. Okay, okay.
And think of that word supraventricular tachycardia, supra, above. It's better than the ventricles. So it's above the ventricles. And what you're going to see is a narrow QRS tachycardia where VTAC, ventricular tachycardia is coming from the ventricles. Anything that comes from the ventricles is going to be a big, wider QRS complex.
Got you.
And you can see the width on this right here.
Yeah, definitely can see that difference there.
And here's another example. So you get your sinus right through here. You have one PVC right here, and then you have a bunch of PVCs. You have that bigger, wider QRS complex, and they just have like, 6 seconds, 5 seconds of VTAC there.
And so what does that look like? You said that's not good for the patient. What would you do if you saw that?
So immediately contact the nurse. If you can't get a hold of the nurse, use your escalation. If you can't get a hold of the nurse, you call the charge nurse. I personally never leave a message with the secretary. They are a non-clinical staff. You always want to talk to somebody clinical because you don't know what the secretary is in the middle of, and you don't even know if she's going to understand your message. And for some reason, if you can't get a hold of any of those and you have the capacity overhead page, you do that. Whatever your escalation is for your position. At where Kristen works right now, there's an automatically generated alarm that will go out to their communication device called the Vocera. These alarms, where I'm currently working at, will go to the phone. Emily will have to speak on that, on how she receives those alarms. How well does that work for you, Emily?
Ideally, we would get a phone call from the teletech saying, hopefully, that they had an episode of VTAC that ended. If it's still occurring, it's a medical emergency until proven otherwise. Until somebody has eyes on that patient saying that they're not symptomatic, it's a medical emergency.
Okay, so
if they're sustaining.
So, do you get an alert to your phone?
Yes and no. If you cancel it from Tele, I'm not going to get it. But if you ignore it, we have phones that look like they're from 1995, so they're very old. And they don't really, it comes up and it'll say that there's an alarm, but I'm not going to be able to see any information other than that, really. Like it'll say alarm VTAC. Like whatever your red alarm label is, that's what we get. That exact label. Like it'll be like asterisk, asterisk, VTAC, asterisk, asterisk. Yeah.
That's interesting. So do you think there is a delay? Like if I let that alarm ring for 5 seconds, it will get to your phone? Or if I immediately silence it, it doesn't get to your phone?
I don't know if it works like it does at Main General because I just don't have that. I haven't worked in tele, and then also I feel like I would need to be in the tele room with my phone.
I mean, you could stand next to your monitor in the unit.
Yeah, that's not trustworthy.
Okay, anyways, so communicate, whatever your escalation is. Where Kristen is working right now, maybe it's because I'm comfortable with it. I enjoy what we had set up previously at our other job. What we have here currently in Virginia could be better, but that's besides the point. We do have the capacity to overhead page. If we can't get a hold of somebody and this person was actually sustaining this VTAC, we would overhead page that to that unit and say, So we could overhead page and say all staff to room, whatever, however you want to say it. But luckily this guy stopped after 5 seconds. But still, I mean, he's gonna feel that, he, she, whatever. They're gonna be symptomatic and like, oh, I don't feel great. So even if like it stops or it's a short little run, it's still noteworthy to tell the nurse. They just had 4 seconds of VTAC. Absolutely, call them. So that is monomorphic VTAC, and what that is yeah. I miss a lot of stuff at Main General. We had a good thing going there. So monomorphic VTAC is all the same morphology, all the same shape of the QRS complex. You have a bigger, wider QRS complex, and all of these are the same. Not the same compared to the sinus rhythm, but they're all same to themselves here. So polymorphic VTAC is when you have different shapes. Kind of see where it's a little wonky there and it's negative. It's not a great example of polymorphic, but so you have different morphologies. It's still a faster, wider rhythm. It's gonna just change. So you have 2 or more different foci. Instead of there's one being one excited cell in the ventricle, there's gonna be a couple different excited cells, and that's what's happening. Actually, we have, and also polymorphic. A lot of times I just call it multifocal, and this is kind of an example up right here. So you have sinus. In my mind, it means the same thing, and it does. So you have a wide early beat here, and look at when you're looking at your QRS complex, you're looking at V lead. So this is probably a fusion beat in the middle. But you see how nice and big and wide this guy is compared to over here, and it goes positive, it changes deflections. And this one is wide negative because you would measure the QRS like right there at the bottom of the arrow to here. And then again, this positive one, so it's flipping. So it's coming from left and right ventricle. So that is polymorphic or multifocal VTAC, where the other one was the same consistent QRS complex. This one's a different QRS complex because it's coming from different excited cells. Let's see what else we got.
That makes sense. So it can have positive and negative, and then is that always going to be polymorphic? Is it going to have the positive and the negative, or it's just going to have an array of different shapes, still wide?
A lot of times you'll have monomorphic, where it's just one PVC, or it's one morphology shape because it's coming from one excited cell. The sicker the heart, the sicker the patient, you have a potential for more excited cells. So I don't know if I want to go here, but looking at V lead, when you have a big wide QRS go straight up off the baseline like that, that is going to be a left PVC. And when I say left PVC, it's coming from the left ventricle. When you have a wide QRS like this, it's coming from the right ventricle. And it's really about the brown V lead that we're talking about, on how if it's coming from the left ventricle, it's moving away. No, actually, sorry, it would be, it'd be going towards the brown lead, so it's creating a positive action. So where the right ventricle is depolarizing away from the brown lead and moving away. And it's really, do you need to know those differences? No, like it's wider and faster, and you have multifocal. It's VTAC. It's multifocal VTAC.
And is that also the same level of danger or concern?
Absolutely.
Okay.
More so, actually, because you have excited cells from a couple different chambers, and you especially in the left ventricle that perfuses the blood out to the body, if that is not perfusing to the body well enough, the patient gets symptomatic because they're not getting as much oxygenated blood as they would like to normally.
Yep.
And then the right ventricle is not perfusing blood to the heart itself through the coronary sinus. And like there's a lot to this. So if the oxygenated blood doesn't get to the heart, then the heart is stressed, it's not getting oxygen, and they have the big, classic MI thing. So there's a lot of things going on here. All right, let's see what we got here. Monomorphic, polymorphic. Polymorphic just doesn't roll off the tongue for me, so I always end up calling it multifocal. It's the same, means the same thing to me. Again, these are all different examples. This is just again, looking at Veely, this is just a classic, beautiful example of VTAC coming from the right ventricle. So you have a negative QRS. You can imagine your isoelectric baseline coming right through here. See that straight down, negative deflection, slur on the downward stroke. That you actually do on this example. This is kind of me nerding out, but if you think about the action potential of all cells. So if this excited cell in the ventricle down below, let me get up there. This excited cell down the ventricle down below comes in first, that wave of depolarization is moving up towards the top of the heart. And you can stimulate the atrial chamber with that wave of contraction. So you would have a retrograde P wave, because that's the wave of contraction moves back up and goes back up. So what you're seeing here is this P wave right on top of that T wave. That is retrograde conduction. So this impulse coming from the ventricle is going back up and stimulating, telling the heart what to do. So people will say, oh, it has a P wave in there. And it's associated with this QRS. That can be VTAC. It is, because the ventricle is telling the atrial chamber what to do in this instance. But you don't need to know that. Sorry. I'm really trying to keep it simple here.
That's okay. I appreciate the extra information. I do.
Kristen, did you know not everybody has retrograde conduction? Only 50 to 60% people have retrograde conduction. Let's see. VFib. I recently learned that myself. And this guy, so see above where the deflection is downward off of the baseline, that's a right PVC. That's coming from the right ventricle. Where this one, straight up off the baseline, that's coming from the left ventricle. Left PVCs, or left VTAC, to me, it's so pretty, because if you open up all your leads, you could have more lead potential down here. They'll all be going positive. All the deflection will be going positive. It's just kind of one of those key notes of left ventricular, where up here it doesn't. But these are left, because looking at Veely, they're straight up off the baseline. I don't have an example of VFib. And what VFib is ventricular fibrillation, where AFib is atrial fibrillation, right? So the atrial chamber is in a muscle spasm. With VFib, you can kind of see where this is going. The ventricle chamber is in a muscle spasm, and it's just sitting there and quivering. There's no organized activity. There's no QRS. Possible to have a P wave, but you're never going to see it, because all the fibrillation of the ventricle is going to cover it on the strip. Where this looks ugly and is starting to kind of smooth out, probably go into VFib, it still has some organized contraction through here. I think this continues. Yeah, like see this stuff right through here? It's getting to the VFib area. I mean, we just talked about this, but it's not on my list. Share the file. How do I do that? Or is that you? Just share a picture.
Yeah, I was trying to find pictures, but then the first one that I have actually looks a lot like the strip that you were just showing. So then I tried to find another one.
So, asystole. So asystole is just going to be no activity, be it atrial or ventricle. There's another thing that I have here, ventricular standstill is, and I don't have an example of that either, so it sucks. Ventricular standstill, the ventricle stops working. You can still have P waves, so it'll look like just little P waves marching along, but there's no ventricle response. I'm sorry, I need to put that on the list to find. What else we got? I don't want to talk about that. Did you find something?
Maybe. I don't know. You have standards.
Like a lot of this stuff we can talk about, but let's skip that for now. Let's get into the some blocks. You want to take a break? Actually, can I go? I'm gonna go to the bathroom. Let's just take 5 real quick.
Yeah, break sounds good. I'll be here when you get back.
I was eating my lunch.
You're fine, Kristen. How is it in Maine right now?
Right now it's a little bit raining, misty.
My mother got snow the other day.
Oh, yeah, we did yesterday.
Are you in Maine? Did you say Maine?
Yes, yeah.
I love Maine.
You've been to Maine?
Yes, just a couple times with family. And I was like, my heart belongs there. And they were like, you can only say that once you spend a winter here.
Yeah, exactly. Hey, we've talked about this before. Like, this is like what, 5 months out of the year, it's kind of very miserable. It's very pretty the other 6 months, but that whole from just late November to early May, it's like, oh, no, it's cold, it's dreary, it's brown and black from. Unless you ski or snow sled or snowmobile or ice fish or any of those things, you'll love it. But if not, here it's just a long winter.
Mm-hmm. Yep. Not looking forward to that part.
Yeah. But besides that, I do miss it. It's a different pace. It's a different life for sure.
Yeah.
Are you guys from Maine or just did you live there?
I grew up I wasn't born there, but I grew up in Maine. Recently, me and my wife Emily, we recently moved down a year and a half ago. She graduated nursing school, and she wanted to be closer to her parents and start in a big hospital at VCU or down in here, anyways. So we're here now.
That's awesome.
For now. I don't know. Like, do you know Richmond very well? We're in Shockoe Bottom, which it's a little it's not on the lower end, but there's some unsavory activity down here. And
I always tell people when they're like, my family in Charlottesville say I live in Richmond, and I'm like, I do not live in Richmond because I live more in Henrico, and it's very different. So Virginia, I has so much to it, but you could easily go a little bit more west and be so much further from the city too. But then again, working at VCU, it's going to be a commute to get down there. And then Jeff, you're not at VCU?
I am at VCU. I'm in telemetry.
Okay, on the tele unit.
Yep.
Okay, cool. So it's probably nicer to live a little closer down there than.
Riding the bus is very nice. You don't have to pay for parking or find parking. I think if we do it again, we would probably live in a different area, like maybe the Fan of the Arts District or something like that, or still near the bus line. But I'm not very happy with Shockoe Bottom. It's kind of rough.
Well, and all I know, I'm not a partier, but all I know about Shockoe Bottom is that there's a lot of different events and like social party scene kind of stuff.
Yeah, it's an interesting place. Let's say that. Now we know why the rent was so cheap. Emily, you back?
No.
Okay, bye. So, real quick, because I recapped what we did yesterday, because I feel like you deserved it. It's going to be a little bit longer than 2 hours. I do have just a few more things to go through, if you're okay with that.
Yeah, I'm good with that.
I want to hit AV blocks, and then there's some stuff. I don't know if you looked at the Google Doc recently. I've been trying to reorganize and make it flow a little bit better. So I've kind of separated some stuff out to advanced stuff that, if you want, we can talk again later. But if we get through AV blocks right now, I think we could be good.
Yeah, up to you. If whatever you have time for, again, I'm so thankful for this. So we can run over today, and then if you feel like you have enough to do another session and you want to do, then I'm fully on board.
Yeah. So let's do AV blocks, and then we'll really get like, I don't want to say advanced stuff, but like next level stuff on another day.
Okay.
Yeah, I'm just looking at the list over here. Okay, so back to our heart.
Well,
I say no. Go ahead.
I'm sorry. We can email and plan. I'm probably working a lot coming up, but I am off.
You're fine.
An appointment tomorrow, but I'm off tomorrow. And then as far as coming up, my work does their schedule really close. So this Thursday, I'll know if I'm working Sunday and so on. But if not tomorrow, then we can email and find another close time. But just
it's fine.
Yeah. Okay.
I'm pretty easy. I'm only working 2 days a week right now, but I do have a study day I need to do tomorrow because I got a test Wednesday. But beyond that, I'm usually here sitting around playing video games.
Good. Love it. Sounds good. We'll email then and pick another day.
Okay. So, again, real quick, you have your SA node, which is the native normal pacemaker of the heart. That impulse contracts and then goes down through the intranodal pathways and contracts the atrial chamber and gets to the AV node. A normal PR interval. Where's our normal P here? What's that picture? So the SA node, the P wave represents the contraction of the atrial chamber, the start of the P wave there, and the end of the P wave there. But the PR interval is the beginning of the P wave to the beginning of the QRS complex. So a normal PR interval is between 0.12, that's 3 little boxes. So because it's 0.04, right? 4, 8, 12. A normal PR interval is between 0.12 and 0.20. One big box is 0.20, right? So this one is exactly 0.20 because you have 1, 2, 3, 4, 5. So that's normal. That's a normal PR interval, right? So saying all that, it contracts the atrial chamber, gets to the AV node, and the AV node has this slight delay right here. This is called the PR segment. So the PR segment. So that segment is the slight delay of the AV node allowing the ventricle to move from the right atrial to the right ventricle. It's allowing the right ventricle to fill full of blood. And normal PR was between 0.12 and 0.20. That's when everything's working right. So a first degree AV block is when the PR interval is greater than 0.12. Greater than 0.20. My bad. Let's go. See, I need 3 pages now.
And just while you're looking, the AV blocks are another one that I probably have notes in this book about, but when I'm looking at the strips and trying to discern what is what, I'm like, I need to know more about why and what's making it this way because, yeah. Anyways, thank you.
So with all these AV blocks, I'm going to open up another page while I'm talking. With all these AV blocks, there's nothing wrong with the SA node, okay? That SA node is firing that P wave every single time like it should be at 70 beats per minute, whatever it wants to be, right? With AV blocks, the problem is with the the AV node, right? Because it's an AV block. So saying that, there's nothing wrong with the SA node. That P to P is going to march out very regular onto itself. That P wave morphology is going to be consistently the same. What else? Oh, this is the best.
It's the PR interval is going to be different.
I'm finding my strip. I lost it already here. Right there. So the PR interval is greater than 0.20. So if you do your quick little eyeball measurement, look for one that has one big box. See right here, there's one big box on the whole segment itself where the P wave actually starts out there. So this is like a box and a half, right? So if it's half, it's probably like 0.32. One box is 0.20. Then you probably have 3 little boxes. So that's 12. They get the 0.32. So what's happening is nothing wrong with the SA node. That SA node's firing that P wave every single time like it's supposed to, but it gets to the nothing wrong with the SA node. It gets to the AV node, and the AV node says, you're going to delay a little bit longer than normal. And that's all a first degree AV block is. A lot of times, first degree AV blocks, the medical field themselves have created them. Like they're trying to control the heart rate, so they give them meds to slow down the heart rate, so they're actually elongating the PR bullet and things like that. And you can start out the morning to have a first degree, and it can go away in the afternoon, or vice versa. Not unusual to have some fluctuation there throughout the day. Just because you're 0.32 now doesn't mean you're going to be tomorrow. And I don't want to say they're benign, but they're pretty commonplace. If this is getting on the long side, yeah, I'm not going to talk to that. So that's all a first degree AV block is. So you have a longer P interval than normal. Normal P intervals between 0.12 and 0.20. It's greater than one big box.
Okay, and then pretty much normal and sometimes medically induced. And then, of course, with constant monitoring, you'll be able to see if it becomes something not normal.
Yes. And so we have three different types of AV blocks. We have first degree, second degree, and third degree. There is not a transition. Just because you start in a first degree doesn't mean later on you're going to be in a second degree. Just because you're in a second degree doesn't mean you're going to automatically transition to a third degree. So let's get that out of the way right now.
And then you could have nothing and go straight to a third degree.
Yes, absolutely. Okay. Yep. So first degree AV block, just a long P interval, nothing interesting. Again, same P wave morphology, same shape of the P wave. The P to P will march out. Normal sinus beyond that. So you would call this normal sinus with a first degree AV block. How my lat times out so fast? It has this attention thing. If I'm not looking at it, it times out. I have to pay attention to it. All right. Anyway, sorry.
Is that your clock making that ticking noise?
Oh, my
It's the fan.
Oh.
Sorry. Is it bad? I can turn it off.
Oh, no. It's not that loud. I just thought, oh my gosh, he has an old clock on his walls ticking.
I tell you what, I contemplated turning on the AC the other day because it's 75 degrees in this apartment right now and nothing running.
Oh, wow. I wish.
It's awful,
cold.
right?
I'm going to put my fireplace on here.
All right. Again, first degree AV block. This one is riding on the edge of the T wave. You can kind of see your QRS, your T wave, and this extra little bump. That is the P wave. And it's kind of merging together. You can kind of see it in the bottom lead too, where there's get that little bump. Again, greater than one big box. You could measure it. This one's actually probably pushing two boxes. Actually, you can see right here. There's one box and there's two boxes. It's closer to two boxes. But again, all the same criteria for a sinus rhythm, but it has a longer AV delay. First degree AV block. 0.36, I measured it for you. So a second degree type 1 block. Again, with just like all the blocks, there's nothing wrong with the SA node. That SA node is firing that P wave every single time at 70 beats per minute, wherever it may be. All these AV blocks are a problem with the AV node itself. Okay. So with a second degree type 1, you're going to have missing QRS complexes. You're going to have gaps of time. And this kind of goes back to when we talked about pauses and doing that mental algorithm of your checklist of like what this rhythm is. Like, okay, it's fast, slow, narrow QRS, wide QRS. Is there one P wave? No, there's actually two P waves. So you have this guy right here. And then this guy right here, there's two P waves for this QRS right here. Again, right here, there's two P waves. And over here, there's two P waves. You see that?
I do.
So,
is that a characteristic of the second degree, the type 1 second degree?
So what's happening with what's happening with second degree blocks is you are missing a QRS complex. So what is happening is this impulse from the SA node is getting to the AV node. And in this particular example, for second degree type 1, you have an increasing P interval, where a first degree, that P interval is consistently long. This one is increasing. But the P to P still marches out. And when I say that, means that P to P is very regular onto itself. So you don't always get the opportunity to see the lengthening of the PR interval as obvious as you would like. What you need to do is just focus on this extra gap of time right here. And you're going to look at the next conducted beat. You're going to compare this PR interval right here to the last conducted beat over there. See how, I wish I had calipers, but this is a little bit bigger. If you can see the width, that PR interval, that segment right there is bigger than this segment right here. So all you need to do is compare these two beats. Compare that. This is the longest PR interval. This is your reset. That's your native PR interval here. So here are the criteria. Is this P to P has to march out, and the PR interval is going to go longer, missing QRS complex. So what's happening is that AV node is delaying. Eventually it delays so much that impulse doesn't go through the AV node. And because there's no impulse going down to tell the ventricle what to do, you have a missing QRS complex.
And then it resets with a normal one?
Yes. So this is your next conducted beat. That should be your native normal beat taking over again.
Got it.
All right. Second degree type 1. So this is a type 1, but it's a 2-to-1 pattern. So every other beat right here is missing a QRS complex. But you can see if you compare this this particular P wave, that's 200, yeah, is 2 little bumps. You get that bump and that little bump, and that's something else going on with the atrial chamber we won't talk about. But this is all your P wave right here. Those 2 bumps are all your P wave. You can see how it's consistently the same morphology: 2 little bumps, 2 little bumps, 2 little bumps. But look at this segment. Compare this segment. This segment's shorter. This segment's longer. And this is what I'm talking about. It's like you don't always get that opportunity to see that PR interval increase. It's happening so quickly, the next beat is blocked. So if you were to see a bunch of these, you would have to make an educated guess on whether or not this is a second degree type 1 or something else, which we're going to get to.
And is that a safe guesstimate to make? Like, is this a safe enough rhythms to where you can kind of guess?
You could generically just say they are having a secondary block, and that you can't say type 1 or type 2. And that's kind of like going back to like using your resources and at least communicating with a nurse. You might not know everything. Maybe your partner next to you doesn't either, but you at least communicate to the nurse. Their heart rate is dropping, because this heart rate's going to go slow, right? Because you're missing every other beat. Your heart rate's dropping. I got extra P waves. It kind of looks like a second degree. Can you check on the patient? And just communicate what you do know, right? And let the nurse check on the patient.
And communicate everything that you're sure about and what you're thinking about. But if you're not sure about it, it's okay to not communicate that. And of course,
much rather
seasoned, but you'd much rather.
Yes.
Go ahead.
I'd much rather you talk to the nurse and versus not talking to the nurse. You know, there are times people are just like, oh, whatever, I don't know, it's nothing, and move on with their life, and they're missing something.
Yeah.
So
I'm gonna need that on the job training, or else I'm gonna be like over communicating. So I'll learn.
Don't you worry. So again, second degree type 1, the PR interval grows longer, missing QRS complex. So this example is what you call a high-grade AV block, where instead of just 1 missing QRS complex, you have multiple, 3 or more missing QRS complex, 3 or more blocked QRS complexes. It's a high grade. So again, but using your using your 2 conducted beats, your next one, compare this PR interval here to the last conducted over there. See how much longer this is right here. That little notch right there is your P wave, and that's your P wave right there. This is much longer, so you know this had the PR interval progression, which tells you it's a type 1. But then you have a P there, missing QRS, P there, missing QRS, P there, missing QRS, P there, missing QRS. So you actually have 4 missing QRS complexes, which is going to ring asystole, because it's a big gap of time. But then, just because it rings asystole, you want to look at why did it ring asystole, right? You could just say, hey, they had a pause. That's just kind of an umbrella term. We could probably find a better label for that. Look at the rhythm and say, why was there a pause? What's actually going on? High-grade AV block. Okay, so secondary type 2. Type 1, the PR interval goes longer, and missing QRS complex. Secondary type 2, you got a question there?
Yes. Is a high grade AV block, is that under the second degree AV block?
So
Or
a
is that
high grade,
insane?
all that says is 3 or more blocked QRS complexes. So you can have a high grade with a type 1 or a type 2.
Okay. That makes sense.
Okay. So secondary type 2, the PR interval stays consistent. And I'm actually going to drop down to the lower section, because up here it's a 2-to-1 pattern. Every other beat's being blocked. But down here is a little more obvious. So looking at your QRS, looking at your PR interval, comparing your last conducted to your next conducted, this PR interval doesn't change. But again, there's nothing wrong with the SA node. So what that tells you is this P to P has to march out, and it does march out. The P to P is very regular. The P wave morphology doesn't change. The PR interval doesn't change, but you have a missing QRS complex. This is a second degree type 2. With a second degree type 2, I'll let you write that first, sorry.
Okay, we're good.
So secondary type 2, we bundle it in with AV blocks, but it's really not a problem with the AV node. So the AV nodes here, and just below the AV node in the junctional area, there's the bundle hiss, the bundle branch areas. So previously in this patient's life, they had some sort of cardiac event, electrical pathway blockage. So there's a little detour that it's called a bundle branch block. And like a little branch here is blocked, so that impulse slows down and has to go around that detour. It's just like driving, right? So with a secondary type 2, that block happens sporadically. How do I say this? So secondary, go ahead.
You might be saying it right now, but the type 2 AV block, second degree, is the bundle branch block? Not always.
It's part of that. Okay. So it's a problem with the bundle hiss, the bundle branch area. So the electrical pathway is sporadically blocking down there. So, and there's no rhyme or reason. It just all of a sudden decides to block. Instead of forcing the impulse to go around and do a detour, it just blocks. So that's why you don't have a PR interval change. It's just randomly missing QRS complex. So then you want to look at, make sure the P to P marches out, saying, and that tells you the SA, there's nothing wrong with the SA node. And the other thing, because there's a problem in the bundle branch area, 75% of the time, you're going to have a wider QRS than you normally would. Not all the time, but a large portion of the time, you're going to have a bundle branch associated with this secondary type 2. So scrolling back up to the top part and remembering, again, making that educated guess when you have every other beat being blocked. Right now, you can't tell, if you just had this top section, you can't tell if the PR interval changes. And so you can't tell for sure, is this a type 1 or type 2? Because you don't see the PR interval change. What you can do is say, okay, I have a bundle branch block associated. I'm going to err on the side of caution and call it a secondary type 2. Secondary type 2. Again, another example. This one's quite obvious. I think I actually generated this with the computer. But that P interval does not change from here to here. This P to P marches out. You have a Y QRS complex, secondary type 2. Again, another example of a 2-to-1 pattern where you don't get to see if that PR interval is changing, but it does have this wider beat. So you're just going to call it a secondary type 2.
So could it be the second degree type 2 with the 2-to-1 ratio?
Could it be a secondary type 1 with a 2-to-1 ratio where you're not? So,
Or well, can a type 2
let's go ahead.
have that ratio?
Yes. So a type 1 and a type 2 can have the 2-to-1 every other beat ratio. And that's what I mean, like with a type 1 where the PR interval increases, with a 2-to-1 ratio, it happens so quick you don't have that opportunity to see that increase of PR interval. So you can have every other beat blocked with a type 1 and type 2. And that's where you just err on the side of caution. If it has a Y QRS complex, a bundle branch block associated with it, you're going to call it a secondary type 2. But also, you got to think, if it's blocking every other beat, the heart rate is also being cut in half. So that's also noteworthy. You're going to have a sudden alarm of like bradycardia. Like, okay, why are they brady? Why is this alarming? Why did they get slow all of a sudden? They can still communicate with the nurse saying, I can't tell if it's a type 1 or type 2, but it's cutting the heart rate in half and I got extra P waves. So, third degree AV block, or what's called a complete heart block, is using the same mechanism as a secondary type 2, where you have this problem in your bundle branch area that sporadically, randomly just blocks a beat. It now is completely not letting any beats go through. It's completely blocking the AV the AV node. So there's no communication between the atrial and the ventricle chamber. So again, with all these blocks, there's nothing wrong with the SA node. That P to P is going to get fired from that SA node every single time at 70 beats per minute. So what you're going to see with a complete heart block is this P to P is going to continually march up. It's hiding inside this QRS complex. It's right there. And it might look like every once in a while, the P wave kind of lines up and looks like it's working with this QRS complex, but that's just coincidentally marching out, right? So what you have to envision, like this atrial chamber is going at 70 beats per minute. The inherent heart rate of the ventricle is between 20 and 40. So none of those impulses are coming down through the AV node to tell the ventricle what to do. So that heart rate drops to that 20 to 40 area. And so the ventricle says, all right, nobody's telling me what to do. I have to do it on my own. So then it contracts on its own. Anything that originates from the ventricle is going to be a big Y QRS complex, right? But then that is going to be very regular onto itself. It's not an excited cell. It's an ectopic pacemaker cell coming from the ventricle. So that R to R is going to be very regular. The P to P is going to be very regular, but they're not talking to each other. The P wave is taking care of the atrial chamber. The QRS is taking care of the ventricle chamber.
I'm with you, but that's just really cool.
It's cool to watch. It's not cool for the patient. So again, it's that bundle branch area problem where instead of sporadically dropping a beat like a secondary type 2, it completely stops all communication.
So what of these, or are all of them bad? Like, what's your highest level of concern for a block? This one.
Third degree.
Okay.
Yeah.
But
There's a couple things. There's a couple things going on. It's first of all the heart rate. The heart rate that's perfusing to the body is going to be super low. It's going to be that ventricular rate that's pushing the blood out to the body is going to be between 20 and 40. And then there's no synchronization between the atrial and ventricle. So the contraction that's usually very consistent and uniform is thrown off. So there's blood's not fully filling chambers or not fully leaving chambers. There's multiple things going on there.
yep, complete heart block. That's what
Yes.
Chris.
Okay. So this one, again, a complete heart block, which is a little bit more obvious on the bottom strip, where you can see all these P waves marching out. It looks like, hey, this one might be lining up, but it's just coincidentally because you don't have that consistently there. So this P to P is marching out, this R to R is marching out, but there's no communication. But now that I have this section right here, I am going to use this as an example. This is what you would see with ventricular standstill. And there's something else that's causing this pause, but if you were just to see this, this is what I would call ventricular standstill. What's happening is the ventricle has stopped working, right? Ventricle standstill. But there's nothing wrong with the SA node. The SA node is still working, right? You still got P waves. So that is what you call a ventricular standstill if you just were to see this. But the bigger picture is, yes, complete heart block. I'm just using that little section as an example. Nope. Too much. I am going to go to one more thing, and I think we're good for now. We're going to scroll back up to PACs. I can find them. And PACs, this is going to tie into secondary blocks in a sense. So secondary blocks, there's nothing wrong, or all the AV blocks, there's nothing wrong with the SA node. That impulse from the that atrial activity is coming consistently from the SA node, right? So that P to P is morphology is going to stay the same. That P to P is going to march out. But the problem is with the AV node. So PACs, they are excited cells in the atrial chamber, right? So you have sinus with that P wave, and then you have that excited cell in the atrial chamber where you have a premature atrial contraction. So you have that early beat. And then you can have a different P wave with that PAC, right? Because it's no longer coming from the SA node, it's coming from the atrial chamber. So there is a thing called blocked PACs. So what's happening is you still have that same mechanism where you have that excited early contraction of the atrial chamber, right? But that impulse comes in so early that the AV node says, nah, you're not going down and tell the ventricle what to do. So what you're going to see on paper is you're still going to see that early P wave. See how this P wave marches out up until here? See how much closer this P to P is compared to this P to P?
Yeah.
Right? So this is an excited atrial activity. You're going to have, first of all, a different P wave morphology. See how this is nice and rounded down here, and this is pointy right there? Because it's coming from a different area. It's no longer coming from the SA node. This guy is coming from the atrial chamber. So you have a PAC there, but you have a missing QRS complex. This is what you call a blocked PAC. Again, that impulse comes in so early, the AV node doesn't allow that impulse to go down through, so nothing is telling the ventricle what to do. You have a missing QRS complex. So I'm talking about this now because sometimes it's easy to confuse blocked PACs with secondary blocks because you have that extra P wave, right? But with secondary blocks, there's nothing wrong with the SA node. That SA node is going to fire every single time. So it's going to have that consistent P interval where it should normally be out here, right? And then morphology of the P wave is going to be the same, where this is different. So if you see this gap of time extra P wave, you've got to make sure the P to P marches out and the P wave morphology is the same. Because if it's out here and it looks the same as these guys, it's a secondary. If it's early and blocked, it's a blocked PAC.
That makes sense. And this was a good time to circle back to the blocked PACs. Yeah.
Yep. So I think there we are good. There's plenty of things I could talk about, but I think 2.5 hours is enough. Any questions before we take off?
I don't think so. I'm feeling really good.
I'm going to stop recording, and then we can talk shit. I mean, talk. Oh, Kristen's still here. Damn
it. So you can't talk about me.
Oh my God. I don't even know if I can stop recording here.
Well, while it's still on the record, Jeff did say that he misses everybody in Telly at Main General, including Kristen. Kristen was mentioned by name. So talk all the